Okay, so hi everyone, welcome to the Keto Celebration. Thanks, Stephen, to let me the opportunity to show that study for the kidney disease. So basically, how it's going to work, I'm going to try to see how it's work. Then we're going to go for a research focus. So the main hypothesis is that we have outside of the box. So early this morning, we talked about the brain, but we think that they have maybe a relationship between the brain and the heart, and maybe there's another relationship between the brain and the kidneys. So we're going to talk about the axis of heart and renal loops. We're going to do a review of our recent published paper that we performed together. Then after that, we're going to move to the chronic kidney disease, where we're going to explain the study design, material and method, and the early result analysis. So that's good. So now we have to talk about the axis renal and kidneys. So you have to understand that if we have problem with the heart, that's going to impact the kidneys. And if the kidneys didn't work well, that's going to impact the heart. So that's the loop that you have to keep in mind. And they have common risk factors. So if we're talking about diabetes, if we're talking about high blood pressure, if we talk about inflammation, those could affect both systems. Actually, if you do the couch potato and you do low physical activity, you will have impact on your heart and you will have impact on your kidneys. And this is true also for obesity. And if we move on with the same common thing, we can think about hemodynamic disease or with metabolic syndrome or obesity or inflammation will actually impact heart and kidneys. And why I'm talking to this, it's because we think ketone could be involved on those axes. And we have already some medication who's going to be used to treat hypertension, who's going to act on the heart and the kidneys. And we also use the GPL1, and the new one from the last decade is the SGLT2 inhibitors. The one who's actually used for diabetes. At first, it was taken to get rid of the endogenous glucose in the blood. And they observed that the liver is working well and the glucose blood levels going down. But they figured it out that if you take that medication, you help also your heart. And now for heart failure, they can take SGLT2 inhibitors to improve actually risk factors and get rid of the hospital. So back in the days, only 5 years ago, there's a Professor Cunan who's actually agreed to be a participant of the study. So basically, we scan his brain, and after that,
we didn't find anything, really looking elsewhere.
To keep my word. But no, actually, with a ketone supplement, we look at the brain for the first 30 minutes. And after that, we go head to toe to figure it out where's actually the ketones go. And here, I don't tell you who it is, but you can figure it out. But here you have the heart who have a higher uptake, and here also the kidneys. So those two organs are a big player in the energy consumption. So, okay, yes, ketone could help for the brain, but ketone could be involved in the heart and the kidneys. So we all see that early in the morning, but MCT, ketone ester, or beta-hydroxybutyrate salt, they go through the liver or they go in the blood, could be targeting for an organ who's actually greedy to have some energy. And actually, ketone is a powerful energy substrate who's giving a lot of ATP, and that's awesome. So that's the first thing that we say, oh, let's move to something else. Let's see how this axis for the heart and the kidneys work. So we published 2 years ago a paper actually where the PI was Professor Croteau and other people here in the room. And we used 2 radio tracers. So we want to know what's going on with the oxygen metabolism. And the oxygen metabolism, we can do it with the radio tracer we call acetate, who's actually go through the mitochondria, and we say how many ATP can work or can produce. And we have the ketone, the one that Stephen worked for the last decade with it, to see what's going on in the brain, but we see the behavioring or the mimicking of the ketone for the heart and the kidneys. And there's only one step away from each other's. If you think about it, you have an index for the oxygen consumption, and for the ketone, how the lasers work again. I have to click on it.
I think you just know when you. Okay, now we get to the area. Here. We change the slide. And now it's going to work for it now. Should.
Work. Okay. So basically, this is the ketone who actually one step away to be acetate. And they ended up both in acetyl-CoA to go on the Krebs cycle to produce ATP. So that's awesome. So what we figured it out, it's the difference between oxygen consumption indicators or ketone. It's about the same uptake. This is a heart. So if the people are not get used to seeing those kind of picture, it's basically the black and white ladder are a CT scan. So it's the anatomy of the whole body. And the one with the color is the radio tracer that we inject in the vein and go inside of the systemic blood and actually get fixed here to the heart. And this is kidneys. So we have to figure it out that we cut something because one is at the back and the other is at the front. But believe me, this is heart and kidneys. And what we figure, it's the clearance. When we talk about the clearance, it's when the radio tracer is inside of the organ, then they go out. It's a washout. And the washout represents the metabolism. So basically, if we use acetate, then you go to the mitochondria, they went out in CO2 and go back in the blood. So it's a little bit faster for acetate than the ketone. And what we observe for the kinase is the uptake at first is a little bit higher, but it seems to be, oh, what is that spot? So it's urine, so it's going to go in the bladder. So we have 2 different mimicking of one step away of a molecule. So that's pretty good. So let's go further. So we see here in blood that we have almost the same mimicking. If we go on the heart, the acetate is a little bit higher, so the washout is a little bit lower. So it's not exactly the oxygen consumption, but it could be ketone consumption or metabolism. And here, what a surprise, we observe that the acetate is a little bit higher and they're going faster for the clearance. And with those fancy stuff, or actually that's going to go through the bladder, we have to do something else. So our first result was, let's move to something else. Let's try to study what's going on when we have different conditions with the ketone radio tracer. So Valérie at the back lead that project like a real PI, really good job. And we have 4 conditions. So basically, we use the same radio tracer 4 times, and we look at for a fasting mode, one with a boost, the bad glucose, and the other one was a ketone supplement. And we want to see what's going on if we mix both of them. And you have to keep in mind that we see something that's going to the bladder. So we have on the kidneys here an expression. So we perform a scan, a whole body scan. This time it's not Stephen, but we have some healthy participant who accept to go to that study. So basically the first 30 minutes, we look at the heart. And the kidneys are downstairs. Then after we have the bladder. So, and with those 4 conditions, we have to perform kinetic modeling to perform analysis to see how it's and keep that in mind. K1, we're talking about uptake. We're talking about perfusion. So here it's the radio tracer who's going through the blood, the one that we give the injection and going inside of the organ. So it's the heart or the kidneys. And K2, it's the clearance. K2, it's the metabolism, the consumption. And it will be different for the heart and the kidneys because the heart didn't have urine or they won't go to the bladder. So we have to put another box to actually perform the good kinetic analysis. And what we observe, it's here for the heart, the bad glucose will increase the perfusion. So it's the fed mode. And when we're fast or with a ketone body, it seems to affect the perfusion of the heart. And what we see for the K2 metabolism, the clearance, we observe that with ketone, we have higher metabolism instead of when we use the bad glucose and the fast mode. And the right ventricle, it's the lazy one. So they didn't have any change on the perfusion, but for the metabolism, it's been impacted because it's probably impacted only because we're taking some higher volume in the stomach that it's going to be affect with the loop of I have to work more to digest what I just intake. So we have this awesome picture. So basically, if you're fast or fed with the boost, the glucose one, the uptake of the ketone stay the same. But if you have supplement with ketone, there's a higher uptake. So what we conclude with that, we have those 2 groups, the young healthy one and the older healthy one. And older you get, more ketone that you will consume by your heart. Because here you be a good student and you remember that the K2 is the metabolism and metabolism of the ketone. For the kidney, we put the other box, and what we observe, we was a little bit surprised that it's different. So basically, fast with or without ketone, there is no difference on the perfusion. But what we can observe is the kidneys will work with supplementation of ketone, higher supplementation, higher metabolism of the ketone. So okay, that's a good thing. Let's go dig further down to figure if we can extrapolate or find something else new. So Dr. Farhan, at the end of the day, will talk about the heart failure. Now I'm going to talk about, it's not renal failure, it's chronic, it's CDK. So it's chronic disease, chronic kidney disease, CDK. So recruitment is done and analysis is ongoing. That's the design. So we recruit 15 patients and they need to be fast 4 hours before the first PET scan. And we asked them to drink a glass of water to 50 ml, no, to 500 ml before the scan, because sometime when you're CDT, you are restricted on the volume that you can take. And we do prospective randomized analysis where we inject the oxygen metabolism at first or the ketone radio tracer. Then we have the 30 minutes left and we do the other one. So keep in mind that the kidneys look like an orange, and the skin of the orange, it's where it works. So it's really thin, the portion that they work. And here we have the glomerular and the distal and proximal tubular, which is going to have like the expression of the urine. So that's exactly where the nephron, like only the skin of the orange work, and the other part of the kidneys is only like the it's not the bladder, but it's the cortex and the pyramid who's going to drain all the urine to go in the bladder. And an amazing fact: when your grandma told you that they have back pain, some kidneys twist. I don't know if we can say that in English. Un tour de rein. What is the translate of that?
Don't know it.
Yeah. Okay. So they will say that they have kidney problem, but keep in mind that it's not true. It's not close to the hips. It's actually the first lumbar. So it's in the middle of the main bone. Oh, it's a lie. So if we move back to the kidneys, to know how good they work, we talk about glomerular filtration rate. So it's GFR. And if we are 100% to 60%, we have normal filtration for the kidneys. And if we go further down, we go on moderate. And when we are like severe, we think about like transplant or diodes or something like that. So what we have in inclusion and exclusion criteria, we want to target the people who have chronic kidney disease. So it's a condition where the kidneys is not being able to filtrate the blood properly. And the disease and the condition that cause CKD are glomerulonephritis, high blood pressure, diabetes, or it could be polycystic kidney disease, to name only those dominant problems. The medication that will be used for CDK, it will be the ACE inhibitors, and the diuretic one with the Lasix. So basically, we're gonna try to put the high blood pressure down without putting down too much, because if we can avoid the good filtration. So that's the challenge that we have to deal with that. So the two first published papers, 223 and 224, are on the healthy person. The blue are the young one, the green are the older one. And if we can drag a line here, CKD are the one with the kidney disease. Inclusion criteria was BMI, so not too obese, between 20 to 40. And we have the GFR between 30 to 60, and stable symptoms without no change of medication in the month. And exclusion criteria was diabetes type 1. It's obvious. Active cancer or liver disease, but the severe one, heart failure, stage 4. As you can see, was surprised the disease recruit more men than the healthy volunteer, where we have more female on keto bent and hard kidneys. So basically, we have 2/3 of male on that study, and here you can see like the glucose is really high. Instead of 5 to be like the regular level that we expect, we are at 8. And even with the hemoglobin glycate was OR7, and here we just show that we target 30 to 60 on the GFR. So here the result, we were surprised, but it seems to have no difference between CKD and healthy person on the perfusion. So if we inject acetate, the one with the oxygen consumption index, and the ketone, it didn't change in the perfusion. But here, you have to keep in mind ketone metabolism, healthy person, older, and CKD. So they basically consume more ketone for the heart if you have a kidney problem than if you are healthy. Okay, we can live with that. And here are for the kidneys. So the kidneys, it's obvious you have a kidneys problem. So the perfusion went down to 50%, and the metabolism's going down also. So here you have on your right, the oxygen consumption is going down, and the ketone metabolism going down too. Okay. So to put light on those results, you have the healthy young that they're going down, and they're going up, sorry, on the consumption for the heart, but for the kidneys, you're going down for the perfusion and the metabolism. And you're getting older, you consume more ketone that still remain, even with the CDK group. Most of the people who have kidney problem are diabetic. So on the 15 people who are recruited, 9 of them have diabetic problem, and 7 of them are already under SGLT2 inhibitors. So, and you can see like the diabetic glucose was 8.6, and with SGLT2, it seems to benefit on the glucose blood level, and the hemoglobin glycate didn't change. And if you move to the results, there's it seems to improve the perfusion and the metabolism of the heart, where we have not that much change on the kidneys. So the question before the conclusion, would CKD patient benefit from a ketone supplementation? We don't know yet. What are the metabolic deficits of the kidneys? Where exactly do we have to target, like the glomerular system, or the tubular, or the distal, or the proximal tubular function? We know that they have some pathology who's actually put light on impairment of the mitochondria, so that could explain what's going on the CKD, but we still don't know. So why diet associated with reduced oxygen metabolism in the kidney? You have to think. I don't have that answer yet. And the take-home message are: the older you get, more ketone you will consume with your heart, and the perfusion, no matter what, if you're healthy or not, seems the same for the heart. That's the opposite with the kidneys. So kidneys, if you have like the CDK, you will have a reduce in perfusion, and you will also have a reduce in the ketone metabolism. So is ketone supplementation may restore some of this metabolism? We don't know, and that's probably going to be the next step that we're going to explore for this study. Thank you.